disorders. These are the group of conditions occur when the muscles, ligaments, and connective tissue supporting the pelvic organ, bladder, uterus, vagina, and bowel become either weak, damaged, fail to coordinate properly, and fail to coordinate properly with as because they are weak. Pelvic floor disorders causing symptoms related either to the support, to the continence, or to the pelvic functions. Now, there is a muscular and fascial hammock. The pelvic floor is a dynamic muscular and fascial hammock made mainly of the levator ani group plus connective tissue, providing the support and the continence for the bladder, uterus, vagina, and rectum. The pelvic floor forms a broad sheet from pubic bone to the coccyx and side wall fascia, supporting pelvic viscera and resisting rises the intra-abdominal pressure. These muscular and fascial hammock is levator ani, which is made up of three muscles, puboroctalis, pubococcygeus, and iliococcygeus, is the main muscular component, stabilizing the pelvic organs and controlling the opening and closing of the levator hiatus, crucial for a urinary and a bowel continence. Endopelvic fascia, this is a pubocervical fascia anteriorly, and rectovaginal fascia posteriorly, and the pelvic ligaments form a connective tissue hammock under the urethra and the bladder neck, explaining the continence mechanism in the hammock hypothesis. Now, pelvic floor disorders, we divide it into 5 types. Number 1 is pelvic organ prolapse, in which the descent of either the uterus nor vaginal wall, vault, bladder, rectum into or outside the vaginal canal. Then the type of continence, this is a urinary continence. It's an involuntary leak of the urine, typically stress urinary incontinence, leak with cough, sneeze, and exertion, and urgency of continence or overactive bladder. We can divide the urinary continence into 4 types: stress continence, urge incontinence, overflow incontinence, and neurogenic incontinence. Stress incontinence is due to increased abdominal pressure, under stress, and the weak pelvic floor muscles. Urge incontinence due to the involuntary contraction of the bladder muscles. Overflow incontinence due to the blockage at the level of urethra. And neurogenic incontinence due to disturbed function of the nervous system. So third is anal or the fecal incontinence. It's an involuntary loss of gas, stool due to impaired anal sphincter or a pelvic floor support. There can be a defecatory dysfunction, either difficulty, straining, incomplete evacuation, or need for the manual support during defecation due to pelvic floor function. Fourth is a chronic pelvic pain. It's also pelvic floor related. Persistent pelvic ache, deep vaginal or perineal pain, sometimes radiating to low back or thighs, often worse on sitting, intercourse, or after prolonged standing. And it is all due to the hypertonic or the spastic pelvic floor muscles. Then fifth is a sexual dysfunction. It can be dyspareunia, especially deep or the entry pain from the hypertonic pelvic floor and associate prolapse, or reduced sexual satisfaction, fear of intercourse because of pain, heaviness, and urinary leakage. Now, when we talk about the pelvic floor disorders, we should know what are the key symptoms. First is the vaginal bulge or something coming down. Pelvic heaviness, fullness, often worse at the end of the day. Then urinary symptoms, leakage with cough, sneeze, exertion, urgency, frequency, and difficulty in starting or incomplete emptying and rushing to the toilet. Then bowel symptoms are constipation, straining, need to change position, or press vaginally, perineally to pass the stool, gas, or the stool leakage. Then pelvic or the low back ache, it can be pressure, pain during intercourse, and during or after the urination or the defecation are there. Now, these are the major risk factors when we talk about the pelvic floor disorders. First is the obstetric, very important, either pregnancy, vaginal delivery, can be instrumental for such delivery, prolonged second stage. Then fetal macrosomia, higher parity, aging, menopause, Older age, low estrogen weaken the connective tissue and the muscle support. Third is obesity and raised intra-abdominal pressure. High BMI, chronic cough, smoking, COPD, chronic constipation, and the repeated heavy lifting. And pelvic surgery, especially the hysterectomy and the prior to prolapse or the incontinence surgery. Other major risk factors can be a family history of connective tissue laxity, diabetes, smoking, sedentary lifestyle, and the lack of exercise. Surgical and iatrogenic factors are the hysterectomy and other pelvic surgery. Hysterectomy, especially without proper wall suspension, which interrupts the uterosacral and the cardinal ligament support, increasing risk of wall prolapse and pelvic floor symptoms. Other pelvic surgeries and reconstructive procedures may alter the normal vaginal support axis and damage the nerves or the connective tissue, contributing the later dysfunction. Aging and menopause. Why it happens? Because the collagen and elastin content becomes less, quality of pelvic connective tissue decline, tissue become thinner and less resilient, and prolapse often manifest or worsen after the menopause. Increased abdominal pressure, we have already covered it. It's a repeat slide, but obesity, chronic cough, heavy lifting can lead to these things, all points. Now, what basic evaluation we should do when we have a patient of pelvic floor disorders? Proper history, what is the obstetric history, what is the gynec history, when she had a menopause, no menopause, all the history points. But the special consideration should take the history, that's a urinary, it's a stress versus urgency leakage, frequency, nocturia, incomplete emptying, pad use, bowel, constipation, straining, incomplete evacuation, need for digital support, then gas, stool incontinence, prolapse, sensation of bulge, dragging, worsening by evening, impact of quality of life, and what is the sexual function. Obstetric and surgical history, parity, instrumental delivery, previous hysterectomy, then POP, SUI surgeries, pelvic radiotherapy, chronic cough, constipation, and heavy work. Now, during the examination, in general examination, we should know the BMI. If there is a history of cough, then cough, abdominal examination, basic neuro, if indicated. Pelvic examination, inspection of vulva, any urethral lesions, atrophy, visible prolapse, cuff stressed, bimanual examination to exclude masses, speculum examination with Valsalva, simple POP grading, then POPQ concept level, rectal tone, sphincter defects, masses, fecal loading in women with bowel symptoms. Basic test at OPD level, urine analysis, culture, post-void residual scan, if voiding symptoms, ultrasound, urodynamic imaging, only when diagnosis is unclear and red flags are present or the surgery planned. Now, connective tissue and changes the integral theory for the pathophysiology, and this is a Petros and Almaston theory in which they say that the laxity arises from the vagina or the supporting ligaments due to the altered connective tissue. Other theory can be organs are suspended by key ligaments and they become weak, and because of that all the problems arise. Now, what are the red flags when we talk about the simple pelvic floor disorders? First is hematuria, especially it's painless, recurrent gross hematuria, persistent microscopic hematuria, unexplained vaginal bleeding, postcoital bleeding, ulcerated or irregular lesion, cervix, vaginal wall, vulva, considered malignancy. Then severe or atypical pelvic pain, sudden onset of pain, systemic feature, fever, weight loss. Then these are the red flags. Marked neurological signs, lower limb weakness, saddle anesthesia, loss of anal wink, new onset of urinary retention, or true overflow incontinence, suspect spinal or neurologic causes. Now, what are the first line management? First line management is first and foremost, if there is a BMI is more than 25, the patient should go for the weight reduction, and there should be every 5-unit drop of BMI reduces POP symptoms and incontinence episodes. Now, treat constipation, adequate fiber, fluids, regular bowel, avoid straining, bulk laxative, or stool softness as needed. Then treat chronic cough, smoking cessation, treat COPD, asthma optimally, avoid or minimize heavy lifting, prolonged standing, use good mechanics. Then pelvic floor muscles training, that is we call it PFMT or the Kegels, and how to do the Kegels. Identify pelvic floor muscles, ask patient to stop urination midstream, once to find the right muscles or squeezes if stopping gas, then lift inwards. Number 2 is empty bladder, sit or lie comfortably. Third, tighten the pelvic floor muscles, squeeze and lift for 3 to 5 seconds and then relax completely for 3 to 5 seconds. Do 2-3 sets daily, morning, or repeat 8 to 12 times per set, afternoon and evening. Avoid holding breath, squeezing buttocks or thigh, focus only on the pelvic floor. But if when to revert to the physiotherapist when there is a technique is uncertain, unable to feel the contraction, or no improvement after 4 to 6 weeks of the home practice. Severe symptoms, mixed or hypertonic dysfunction, need of biofeedback and electrical stimulation. Now, after the first line treatment, pacemaker for the pelvic organ prolapse, indications are symptomatic prolapse women in not desiring surgery, medically unfit for surgery, or wishing to defer surgery. Follow-up and care, initial review at 1 to 2 weeks to check fit and comfort, then 2 to 3 monthly if patient cannot self-manage. If patient can self-remove and clean, 6 monthly review is acceptable. And vaginal estrogen in postmenopausal women helps to prevent the erosion and ulceration. At each visit, remove pessary, inspect vagina for ulcers and erosions, clean or replace pessary, and reassess the symptoms and satisfaction. Now, when to consider surgery? Indications for surgery: when there is a persistent bothersome symptoms, quality of life despite the adequate conservative management, 3 to 6 months of a pelvic floor management, that's a Kegel exercises being done, lifestyle measures done, pessary trial being failed. And failed or unsuitable pessary, patient preference for the definitive treatment after the counseling. Now, surgery for the pelvic organ prolapse, that's a POP, main approach. First is a vaginal native tissue repair, anterior and posterior colporrhaphy, plus apical suspension, uterosacral and sacrospinous fixation with or without vaginal hysterectomy. Abdominal or laparoscopic sacrocolpopaxy or sacrohysteropaxy can be done. Mesh or graft from vagina, uterus, or sacrum to restore the apical support. Obliterative procedures like colpoclasis in a frail women with no longer desire for the vaginal intercourse. Then key procedures to maintain when we are doing the stress urinary incontinence surgery. First is the mid-urethral synthetic slings. Second is retropubic or the transobturator slings. The current standard in the many settings providing a suburethral tape to support the urethra during stress. So these are the types. First is the retropubic sling, PVT. That mesh is passed behind the pubic bone, either top down or the bottom. This method is well studied with long-term data but slightly higher risk to the bladder injury. Then transobturator slings, that is TOT, the mesh passes through the obturator foramen side to side, reducing the risk of bladder perforation and lowering the risk of urinary symptoms compared to the retropubic, but the potential for higher growing pain. And third is a single sling incision. It's a mini sling. It's the newest and a least invasive options. Use a similar piece of mesh and a single incision on ongoing studies, long-term and effective. Now, the surgeries for the stress urinary incontinence, when we talk about the Bursch-Colpo suspension, we all should know non-mesh procedure by lifting and securing the bladder neck and the vaginal wall to the Cooper's ligament. And it aims to stabilize the urethra and restore the continence. Then surgery for the urinary incontinence, there are other surgeries. They are autologous fascial sling, using the patient's rectus fascia when the synthetic mesh is contraindicated or undesirable. Autologous fascial sling is non-mesh surgical procedure for stress urinary continence that uses the patient's own tissue, typically abdominal rectus fascia, to create a supportive hammer under the urethra. Bowel dysfunction and the surgery. The indication, structure and sphincteral defect, specific pelvic floor abnormalities demonstrated on imaging, physiology after failure of medical and physiotherapy measures. They can be sphincteroplasty to repair the obstetric and anal sphincter injuries, pelvic floor repairs like levatroplasty, post-anal repair to restore the anorectal angle in selected patients. Levatroplasty is a curved incision is made behind the anus to expose the levator ani muscle, puborectalis, and then the approximation using the suture to tighten the pelvic floor, often in conjunction with rectal prolapse repair. Post-anal repair, a V-shaped incision is used to access and plicate and fold the puborectalis muscles and the pelvic floor and tissue behind the anus, strengthening the posterior segment, restoring the normal 90-degree angle. Now, advanced options, usually the colorectal and urogynecological domain, sacral nerve stimulation, bulking agents, artificial sphincter, or a stroma in a refractive serial cases. Now, what is the take-home message when we talk about pelvic floor disorders? Pelvic floor disorders are common, underreported, highly treatable when recognized early. Think of symptoms in three domains: support, bladder, and bowel. Support, bulge and dragging; bladder, leak, urgency and retention; bowel, constipation, soiling and straining. Major risks are childbirth, aging, obesity, chronic straining, prior pelvic surgery. These are the opportunities for prevention and counseling. A simple focus history plus pelvic and rectal examination is important. The red flags are hematuria, abnormal bleeding, severe pain, and a neurologic sign. First line management is conservative, lifestyle changes, pelvic lower muscle training, and pacemakers. Many women improve without surgery if guided well. The symptoms are significantly affect the quality of life despite good conservative therapy. Timely referral for the appropriate prolapse or incontinence surgery can restore the function and dignity. Thank you so much.